Hi class, in this chapter we're going to talk about global health priorities. So thinking about what are the next steps moving forward? What are the things that we should be thinking about in this 21st century? So something more than like 28 million people die in the developing world of cardiovascular diseases, cancers, non-communicable diseases every year. And so Africa, for example, has a huge burden of non-communicable diseases. They're projected to experience the highest increase of non-communicable diseases and mortality in the next decade. So what does that mean, non-communicable? That means things that are related to lifestyle, to environmental toxins exposure and things like that. So cancers, cardiovascular diseases, certain types of, obstructive pulmonary disorders, and things of that nature. From 2010 to 2030, diabetes type 2 obviously, is expected to increase by 100% in Africa, and it'll increase by 50% globally. And we have higher age-adjusted non-communicable disease death rates in low and middle-income countries, which is, than in high-income countries. So here's a map of what that looks like. So when we say age-standardized death rates, and these four are by non-communicable diseases, what that means is at any given age, it's in a normal population, you'd expect X percentage of them to die, right? And this means not taking that into account. So that means that these are from non-communicable diseases, and it's including both sexes. So you see the really high rates in the darker reds and oranges in, of course, poorer countries. So this is a health inequality that needs to be addressed. And the thing is, with the Partners in Health model, for example, well, just in general, the global health model that we've been aiming towards is having the diagonal approach, remember, right? So we've got these diagonal investments, which means, just as a refresher, the vertical investments are ones where we say, look, we're just going to tackle polio or just tackle HIV, and we go top down, right? Like that's it. We've got one mission, one strategy, one thing. Well, not necessarily one strategy, but we're just going to invest in this. Versus a horizontal approach is where we go, well, let's look across this. We've got a poor population. We need to do nutrition and education and widespread changes. And that diagonal approach was that one that many of the examples we have talked about, which is like you're doing some of both. You are doing some specific interventions for some of those critical, like TB, right, or HIV/AIDS. And then, but you're supplementing it, you're complementing with also like nutritional supplementation, other, supplemental income stipends for education and stuff like that. So essentially, this is the diagram in this figure here for how you would integrate, the existing framework and grow it out to include and help provide care for non-communicable diseases, and this does include mental health, which is one of the things we talked about is really important. So if you think of it, this is what you want to have with your health facilities. You want to have referral centers. You want to have at least one per 2.5 million people. You want to have district hospitals, health centers, and community health workers. So where we have the most, right, is down here at the bottom. And then there's, the referral centers we use fewer of, right? So the community health workers are like the base of the pyramid here. This is the massive coverage. Then health centers, district hospitals, and on up to more specialized care. And that's mirrored here, right? Specialized care, right? You do need some of that, right? But then we have here the nurses and general physicians providing a lot of integrated care here. Then we have integrated chronic care nurses and integrated chronic care community health workers. So essentially, I don't know if it's a perfect pyramid, but that's how I kind of think of it. It's like, this is where you need the bulk of things, and then we can distribute people and use the resources we have to get them, the resources in place to get them through to where they need, when they need a specialist. Like here's an example. This is a fellow in Rwanda, Ernest, and these photos aren't mine, these are from Paul Farmer. He had severe rheumatic heart disease. His liver moved with each heartbeat, okay? And they were able to, through the programs that they described and stuff, he was able to, get into school, lead them, right? This is the before and after, the happy shot, the happy outcome. Another example of how things go in Rwanda, for example, you get these economies of scale going. This is the average, the pink or salmon is the average variable cost per patient, and you can see it varies quite a lot if you have just a few patients, right? Using a particular, so thinking of heart surgery here, cardiac surgery. This is the fixed cost. The black doesn't move. There's a certain amount that's going to be the fixed cost of a procedure, and that's not going to change. But for example, you would say, why is this so different? Well, maybe if you're having to fly in a specialist care provider and a specialist nurse and get special equipment and everything, or transport, that all goes down when you're doing more procedures. It goes down to a certain point. Here you can see between 250, 300, not as much of it's a little bit different, but that economies of scale, meaning if we're able to offer that care and that service to more people who need it, then the marginal costs, right, these variable costs go down. So in fact, we can bring down the cost of what we're offering. Here's an example of, a child who had cancer and needed to have it removed. And so when we can do these procedures, the more we do them, the more the cost comes down. 70% of deaths occur in these low and middle income countries for cancer, right? And the survival rates are much lower also in these countries than in high income countries, obviously, right? Because they're not getting the care. So these are low resource settings. 5% of global resources for cancer are spent in the developing world. That means that 95% of all of the global resources, money, time, energy, physicians, nurses, etc., treatment centers, is spent in high income countries. So factors that contribute to the low survival rates, where they're low, which is in the low and middle income countries, they get a later diagnosis, they get an inaccurate diagnosis because sometimes they don't have the correct tools to make the right diagnosis. And they get ineffective therapy, so they get medicine that's out of stock, there's high cost, limited training among the clinicians, etc., if it's not done correctly. Of course, what do we all want? Well, if you have cancer or a loved one has cancer, you want the best, the most cutting edge, the surest thing. And that's the same care that needs to be delivered to everyone. Everyone in the world wants that. And then there's the hidden cost to patients, right? There's things that provide those hidden costs, right? Are like barriers, out-of-pocket expenses, childcare, transportation, loss of income, So for example, these are from worldmapper.org. If you haven't seen that website, you should. I think you should, in particular for the country that you're researching. So it shows physicians working. This is like per percentage of the population, right? Per like 100,000 people. So you see the countries where it looks really fat, it's because they have many physicians working, right? And then when you see the preventable deaths, so deaths that could have been prevented but weren't, you see the disproportion. It's pretty dramatic and it's pretty marked. And so that's what the priorities are then for the early 21st century, is using the infrastructure we have from HIV, from malaria, TB, the lessons we've learned, the infrastructure that's in place, and putting it to these non-communicable diseases, especially cancer. So there we have it.